difficulties?
We can
Yes.
start and I will figure out how to get that to you.
Ted, I think we just need to know which file the presentation is in. The link you sent us, there's a whole host of files on there. We just don't know which folder it is.
Okay, I'm gonna try to send it directly to you, Julie. Hold on.
Okay.
We will start the meeting shortly. We are paused for technical difficulties.
Yeah, she did it. I see her. Okay, so she.
We can go out of order if we need to.
So we have. In the halfway presentation, I think so. I think the presentation access. So.
Okay. Okay,
If you're comfortable.
okay, and so pathways is,
Just,
you have
yeah,
this? or
yes,
what?
that one's ready to go. So, and I'll be ready, but I don't have a presentation, so it's Dan's presentation. We don't have that quite yet uploaded.
Julie, you
Okay.
should have the file in your email now. We are live streaming now.
So we're going to go out of order.
Yeah.
Okay. Good morning, everyone, on this frosty March morning. It's not January, it is our March meeting, and spring will be coming. I did notice driving down Meridian Street this morning, some of those beautiful flowering trees got frosted. But anyway, other spring plantings will come forth very soon. So good morning, everyone. The first item on our agenda is going to be I just want to announce I am passing around a card for Senator Bro's family. Senator Bro so faithfully represented her district for many years here in Indiana. And so the Commission on Aging, I'm sending a card around to be sent to her family. She passed away earlier this week. Okay, the first item on our agenda is approval of the January minutes, but I better take roll first and be sure that we have a quorum. So, okay, let me call roll. Margaret Smith, are you on the call this morning? Okay. Katie Ellman, are you on?
Yeah, good morning. I'm here.
Morning, Katie. James Gone. James, are you on this morning? Okay. Becky, you are here. Judith, are you on? I know you're having some car difficulty this morning.
I made it.
Okay, thank you. Kelly, you are here. Deb Lambert. Deb, are you on this morning?
I am.
All right, good morning in Fort Wayne. Jennifer, you are here.
Morning.
Dan, you are here. We are one person short from a quorum. So we will wait to see if we get anyone else coming on to the meeting. So what we will do is I'll just ask anyone present, are there any corrections to the minutes? Additions? If not, we will file the minutes for approval at a date when we have, later date when we have a quorum. Okay. We're going to make a little change in our agenda as we're waiting for some technical problems to be resolved. So Dan, we'll call you back in a little bit for your presentation on housing supports. And we'll move to the Pathways Readiness presentation, Kim Bremer from OMPP. Thank you, Kim, for coming.
Yes. Hopefully we'll be able to share slides. Okay. My name is Kim Bremer. I am the Director of Pathways and HCC for OMPP. I'm going to start off and kind of just give you a summary of where we are in our enrollment process for the Pathways. And then I'm going to pass it off to Holly Pickett to have her go into our readiness preparedness, so you see where we are, and we'll have a much more expanded presentation in May, right before go live. So this is kind of summary.
Rebecca, the view.
Sorry about being soft. I scream at my kids all day. You'd think I would be able to scream at them.
Rebecca, we can't see the slide deck in presentation view. It's just zoomed in on the logo right now.
This is James Gahn, and I'm present also.
Thank you, James.
Sorry, I have to use the Zoom browser, so I'm trying to navigate this a little bit. Because we can't have Zoom on our computers anymore. Are you looking at yourselves, or are you looking at my PDF file?
We can see the I think it's the PDF file. It's not in presentation mode, but we can see the slides.
Okay. And are you looking at the agenda slide or the title slide?
The agenda slide.
Okay.
So can you move to the next slide?
If you just
Thanks. Okay, so just to kind of give you a summary of where we are, we have currently already started sending out letters. The letters were started to be sent out in mid-February to the members to allow them to understand the enrollment process, give them contact information to contact for enrollment brokers. We currently have gone through almost all of the letters to members have been sent out. I think we're at 1 week left of the notifications. They are just starting the phone calls to all authorized rep and members are started to go underway last week. They started doing those phone calls. Our Pathways phone number, which is right up there, it's 87 Pathways 4 has been open and available. We're currently tracking all the calls coming in and the conversion rate for those who are picking their plans at this point. We are about, as of the end of last week, we had about 3,300 members that had called in, and about 49% have already chosen their Pathways plan on the initial calls. So the other ones, we have a host of reasons what they were looking into, where there were more questions or they wanted to loop back around to their providers to ensure the right pick of the plan, and that they would be calling back as soon as they were able to determine which plan was right for them. So we also have done some outreach. We have a webinars to the stakeholders as well as to consumers to explain to them how the enrollment process works, to make sure that they have the necessary information when they do those original calls, and so that they're comfortable with that process. And then we're monitoring all of the emails, feedbacks for that, and trying to get the answers as quickly as possible. So far, we've been pretty smooth in our transition. There has been some feedback on some random calls to our brokers that we have been continually going back for more education and making sure those are smoother. So, but overall, there hasn't been a huge pushback, but there's a lot of issues that most of them are isolated and that we're addressing in one-on-one. Next slide.
Kim, I'm sorry, can I ask a clarifying question?
Sure.
I apologize, I missed this. You said the 49% was tied to the percentage of callers to Maximus who have made plan selection?
Correct.
Okay, thank you.
Yeah, so as I said, these are not that the letters went out. This isn't that the calls Maximus are sending out. These are just the calls coming into Maximus off the initial letters. We have about a 49% that are picking at the time of their first calls.
Okay.
Is really what we're looking at. We assume that's going to be picking up significantly, but the good thing is that it gives them opportunity to ask all the questions, and then they're able to think through and then call back and then make that plan selection. So we assume that it would be probably 2 calls for a portion of the members, because they want to process and then determine at that point. So
Great.
I think we're really encouraged that 50% felt comfortable enough on the initial call to even be able to make that decision at the point of.
And this is Deb, and I will also just add to that, that we've been, some of our families asked us to sit in on the calls with them. And the folks have been super, super helpful. And it really has gone very smoothly. So I think we have at least half, if not more, of our residents that live in our community, their family have been able to sign up. So far it seems to be going really well.
Thanks. We love hearing that feedback. So let's go to the next slide. So I'm going to pass it over to Holly and then come back and talk about a little bit more of the engagement afterwards. So she'll talk about the readiness.
Good morning. I'm Holly Cunningham Piggott, and I'm the Director of Care Programs with OMPP. I'm going to go through the Pathways Readiness Review process that we are doing with the MCEs to ensure that they are ready to go live July 1, 2024. As you know, we have the three managed care companies that were selected. It was Anthem, Humana, and United. And then after they were selected, we give them a great big workbook, Excel workbook of all of the requirements that they have to meet prior to go live. And basically, it's this very large systematic process of reviewing staffing plans and policies, processes, documents around subcontracts. We check their system capabilities, and we also review their provider network a few times through this process. The reason why we do this is we have to be confident that when they go live, they are going to meet what is in the contract that we've outlined. And this is our process to do that. And we're also required federally to do some sort of readiness process with our managed care companies. Today, as of today, there's about 270 requirements, which each then have like sub requirements under them that they have to meet to show readiness before they can go live. Where readiness will start it in July 1 of 2023, and it will end April 1 of this year. So April and May are kind of catch-up months. So if there were things that our MCEs were having issues with that we weren't able to check them off when we did the readiness item, maybe it was something about processing claims, then in April and May, we'll go back and we have them re-demonstrate or resubmit their policies and procedures around that so that we can make sure that they are ready. Next slide. And this is just an example of so we do a desk review and we do an actual on-site review. So the desk review, this is an example of, we just did pharmacy this last month, and there's the requirement and the scope of work section that it comes from. And then those A through D are all of the sub requirements that they have to submit to show that they meet compliance, contract compliance. And then the bottom box is what we would do. We go on site and they have to demonstrate then, show us your system. They go into their system and they show us how they would work with a member, like with care coordination or service coordination. And so again, this was our recent pharmacy on site, and our pharmacists had them show how they would process pharmacy claims for these very specific items. So that's kind of a summary of readiness. Is there any questions that I can answer? We're going to do a more in-depth review of all of this in May. So there's more to come, but is there any questions that anyone has right now? Yeah.
I have one for the, you said the provider network for readiness. Is there a percentage of specifically HCBS providers that are fully contracted, or is there a deadline for that? And then secondary, same for service coordination. Are there any providers under contract yet? And if not, what is the deadline for that?
So service coordination is in process. The contracting piece should be wrapped up sometime towards the end of April. So they're still working, going back and forth, the MCEs with CCHI. The provider piece, the MCEs are required to have an open network. So it really, I don't want to say it doesn't matter if they're contracted or not. Providers will still be able to submit claims, whether they're contracted or not with the MCEs. But we will do a provider access report in April, and we'll do another one in July to see where they're at. They are actively, Kim meets with them every 2 weeks, their provider relations folks at the MCEs, so that we can gauge like, where are you guys at with this? And then we get calls too from providers that ask us questions, like I haven't heard from an MCE. So then we're able to kind of funnel that down and follow that through to make sure that the MCEs are contacting that provider.
How long is the open network?
3 years.
3 years?
Mhm.
So for a period of 3 years, if you're not fully contracted, you can continue to bill.
Yeah.
Okay.
And a question I have about contracting is, so I run a skilled care and assisted living. The skilled care is connected with the hospital. So since it's under their number, the contract goes to the hospital. But my license for our community is a comprehensive, meaning both the AL and the skilled are under the same license. So it's going to be under the same provider number. And I can't find anybody that seems to have the answer, like, do I get a home and community-based services contract, and how's that handled?
Yes, there should be an amendment. You should request an amendment under your current facility contract to add that HCBS provider service line. And we'll have more details, explanation. Each of the MCEs are supposed to be producing that within the next week to give you more instructions to ensure that's happening. And we did bring that up in our provider networking meeting yesterday, so that they are aware that better communication needs to be put out for that. So they should be reaching out to a lot of the assisted livings directly to make sure it's clearly defined and that those steps are being done. It would be
Thank you.
It'd be the same too for home health agencies that also operate as a personal services agency under the same provider number. They would just need to request an amendment. And so we'll have the MCEs, we'll be getting that communication out. It'll be on our Facebook site, and we'll make sure that the MCEs get it up on their sites as well.
And will you put out publicly, I don't even know what I mean by publicly, will you share when go live happens around July 1st, the numbers of providers who have actually contracted with plans?
Yeah, most likely we will have that published.
It's just too early to do it now because it's so active. There's
Oh,
a
yeah,
lot still
sure.
pending
Yeah.
in the process, but as we get closer, we'll make sure it's clear. I do want to reiterate that they are reaching out directly or doing physical calls to a lot of the providers that they have not heard back from to start the process to make sure that they are getting the contracts put in.
This is a really high level question, but I think some of these questions are coming around our capacity for home and community-based services. Is it going to be adequate? What's going to happen to people? Where are we looking at it? I know you don't have an answer because you don't have the contracts, but a 3-year open how are we dealing with the capacity issue?
So I will tell you, the provider network piece will be reviewed pretty much every quarter. They have to submit a report every quarter to let us know where they're at. If we feel like they're not compliant with that network adequacy, then, we will issue, guidance on that they need to get into compliance. If they still aren't in compliance, then they could be receive liquidated damages, or they could be put on a cap. Those are very reactionary. I mean, what we're trying to do right now is pre-go live, and this is why Kim is meeting with them every 2 weeks, is see where are you at with these numbers, and for her to kind of drill down and say, this is not good enough. We need better. We need more. I would also say that our DSW work group that is led by Peggy Welch, they're doing a lot of work around the supporting the workforce and alternate ways to support people, like through technology. or through home modifications where if we would just maybe update a bathroom, then we wouldn't need the personal assistance person in all the time as much as they are. So we are looking at some of those things too, so we can kind of maybe shift buckets of money. So we'll do the home mod and then we can maybe have less staffing hours, things like that. So the MCEs are aware that that's what they need to be focusing on. I think that the first 6 months, the MCEs are going to be trying to get everybody assessed. We're using an NRRAI tool. It's the home care tool. We're using that. They're going to mandated to use that tool. So a lot of it will be going out, meeting with people face to face and getting these assessments done so they can really gauge like where is the support needed. So yeah, I think that we'll be providing more and more updates, I think, as this goes live. But I will say our MCEs have really come together to work as one unit. And that has been extremely helpful. They are very collaborative. And actually, they've done this in many other states. So there's some of the times they're telling us, like, this is probably the best way. This is the best practice to do that. So it's been a really, I would say, collaborative relationship between us and our MCE partners right now. And that has been extremely helpful.
It'll be very helpful for providers that they are collaborating, right?
Yeah.
And trying to be as consistent as they can in practices. So we've heard a lot of that.
And we are putting a work group together with the provider, some provider representatives and the MCEs to streamline the claims process, because that seems to be one of the biggest complaints is that everybody does claims differently. So we will be streamlining the claims process so that they all three are doing the exact same thing. And it actually will then match also Gainwell. Gainwell will be part of this work group. So is there any other questions before I step away?
Well, I have a question, and I don't know to whom this needs to be directed, but, and again, this is a high-level question, but I'm just scratching my head, and I've been going around looking at some other states to see, Googling around, seeing how they do things, but I've had some questions from people saying, well, is Pathways the only choice that I have if I qualify for this level? And we have PACE programs.
Right. And we've been very clear. We actually put some FAQs out specifically about PACE because we want to make sure that if someone they have the option to choose PACE or they can enroll in Pathways. We don't want to take that option away from anybody. So I don't know if we've published them yet, but we just put together some FAQs specific to PACE to make sure people understand that Pathways is not, we're not making people go into Pathways if they're in PACE or they want to choose PACE. If they're in PACE and they want to come to Pathways, then they can just call the enrollment broker. And if they're in Pathways and they want to go to PACE, it's the same thing. They can just get disenrolled. But we've gotten those questions as well. And we wanted to make sure we put out some guidance around that.
Well, if people are just directed to Maximus as the enrollment broker, they will not mention PACE. Is that correct? Good.
Yeah, this just came up because I just did a PACE presentation. Currently, we're doing enrollment into Pathways. So there is the Pathways emphasis until July 1st. But no, Maximus is included in their enrollment once eligibility is put in place. And once through the eligibility process, they will always be given the PACE option as well.
Okay, that answers my question.
So there is a little transition period right now that it's not emphasized the PACE option as much as it could be, because most people are calling in saying, I got my Pathways letter. But that is always there, and they have we've just done a new education with Maximus to make sure that PACE is included in those options.
Okay, thank you. And one other thing, maybe you were going to bring this up, Kelly, from our discussion in our caregiver support group, but since you're here, I'll ask. Maximus sent something out that I think had to be corrected. They are not doing the choice assessments.
Correct.
You have that.
Yes. Hello, I'm Leslie Huckleberry. I'm the director for FSSA's Division of Aging. So Dr. Burke, you're referencing an e-newsletter that went out from Maximus that was intended to provide some updates on some of the work they are continuing to do for FSSA and will be doing in the future. And there were a few areas that were a little confusing. And so we have worked with Maximus and have refined our review process for those communications to make sure that it is proactively involving the Pathways team and our communications team within FSSA to make sure we've got multiple eyes on it. So there should be more information coming out imminently to make clear that they are not doing, they are not the ADRCs, they're not doing options counseling for choice. If individuals qualify for choice, they'll still work through the AAAs as they do today. That is not changing.
Thank you.
Yep.
Can you do the next slide? I think we're going to wrap it up to just kind of reiterate the outreach that we are currently doing. So we have a whole side of the provider side, educational webinars, and we're doing association presentations throughout the state for the next couple months. I mean, we have 4 presentations today. So it kind of tells you the scope of it. But we also have done direct to consumer. We're doing engagements. Here is a list of just some of the ones that we're doing around the state. We started last week. We did a sweep of the northern part of the state. We're in the central part of the state this week, and then we're doing the southern part of the state next week. And we're doing multiple presentations directly to consumers to help them through this enrollment process to try to ease that communication gap or to answer questions face to face for those people who feel more comfortable having that personal touch versus being able to get on the phone. So in doing that, as we said, we're very open and we're trying to be as proactive as possible. So PACE came up, and so knowing that that was a little bit of a hole, we filled that gap as quickly as possible. So we are really reacting to anything, but our whole goal here is to be as proactive as possible. That is kind of the update of where we are with the Pathways program. Is there any other questions you may have before we?
Any concerns about any of the plans from a readiness standpoint?
I think that we are working very personalized with each plan to make sure they're up to speed and are ready for it. So while one may be weaker in one area than another, we are having one-on-one conversations to get them up to speed. So we are not feeling uncomfortable at all that they will be ready for go live.
That's great.
One other little comment here. I know there was a little hiccup in the part of the state, or so I understand, with one of the commercial health insurance companies. We've got some providers that may be not renewing contracts with some of these commercial health insurance companies providing managed care. That happened up in northwestern Indiana, as I recall. And and I think people that were in those plans, the AAAs, were called in to help them get to another provider or another commercial health insurance provider. How are we addressing this problem if providers drop contracts? I mean, I'm talking about health systems. Drop contracts with some of these entities. I don't even want to bring this up, but it is there.
Yeah.
So, and it's happening nationally. This is going on. How are we going to deal with that?
So I would say that, because the MCEs needed to add pathways to their current contracts, that opens up the contracts for negotiations with the different health systems. So we have seen some of the health systems really pushing back on rates with our MCE partners. I would say some of the negotiations going on really have been going to the nth hour, like minutes before midnight, and they come to an agreement. But Cora Steinmetz, which is the director for OMPP, she's been in constant contact with the Hospital Association to try to get some of support from them that, some of the things we're hearing is that they don't want to take on more Medicaid members. And what we're trying to get across is that these aren't more Medicaid members, that they're already being served by these hospital systems today. And so we're kind of leaning on the Hospital Association to help us get some of this messaging across. Cora has had conversations with Northwest. Is it a community, I think Northwest. She's been having conversations with them about this. And I don't want to discount the commercial side. Her focus is really Medicaid, making sure that they aren't going to stop seeing Medicaid clients. But she's been trying to have conversations, and then in return, then we've been trying to go back to the MCEs and saying, okay, guys, we've got to meet somewhere in the middle on this. So that's kind of where we're at. I think, again, like, I think because they opened it up, adding pathways, that gave the hospitals an option now to renegotiate, and they're really playing hardball with the MCEs. I don't know if it's warranted or not warranted, but I'm not in that arena, but yeah, we're hearing that. I think St. Francis is another one that has recently served some termination notices to a couple of the not Pathways managed care, but other managed care entities. So
Well,
we're trying to address it. Yeah.
Just to piggyback on Dr. Burke's question, poor Dr. Burke's, I keep sending her articles that I get about CMS's, looking at the managed Medicare entities, and unfortunately the same entities that we have in the state of Indiana that's going to run the managed Medicaid, because they're using AI to decide who gets what, and it's people that are in Medicare Advantage aren't getting the same benefits that people in traditional Medicare are getting, and they find that it's costing Medicare. CMS has put out some studies where it's costing more per person on Medicare Advantage than it costs on straight up Medicare. So I'm just curious what systems are in place to ensure that some of the problems that have happened under managed Medicare, we're not going to see under managed Medicaid, and we don't have people that are going to have AI deciding whether they get certain benefits or don't get certain benefits.
Well, we don't allow AI. It's in the contract that we don't allow them to use AI to make like prior authorization or claims payment decisions. So that's probably the biggest thing that we have in place that will prevent those same issues from happening.
Oh, okay, great. Thank you.
Thank you so much for your presentations. I know we gave you some challenging questions here, but probably just as well they come up. Thank you so much. Appreciate it. Okay, we do have a quorum, so I am going to circle back and see if I can get a motion to approve the minutes for this month. I'll make that motion to approve. Okay, Becky put a motion forth. Is there a second?
I'll second.
Jennifer seconded. All in favor for passing the approval of the minutes, say aye.
Aye.
Any negative? Okay, the minutes are approved. Thank you. And thank you, Dan and Julie, for getting the minutes to us. So, okay, Leslie, do you?
And I do believe we have Dan's presentation ready if you want. It's up to you.
Why don't we go ahead and get your update, and then we'll get over to the advisory committees.
So good morning again. Leslie Huckleberry, Director for FSSA's Division of Aging. I'm going to update you all on two different components. I'm going to give some updates on the Medicaid forecast strategies, trying to address a couple of the questions that I think came up in the January meeting. I was not present, but that's my understanding. There were a couple questions. And then I'm going to give update on non-Medicaid aging related items too, so we can make sure we're also talking about the things that impact the other million or so aging folks in Indiana. So I'm going to start with the Medicaid forecast piece. There were a couple, I think, data related questions that had come up in the January meeting. So one of them, I believe, was a question regarding what was the estimated savings amount related to pausing that 2% indexing increase over the next couple of years that we had previously built in to our rates for the Medicaid program. So I do have that information. That particular pause is estimated to save us $27 million in state appropriation for the current biennium across all impacted provider types. So that is HCBS, home health, ABA, NEMT, and dental. So hopefully that answers that question as it came up. I know there was also a question on whether we have information on the number of legally responsible individuals that are impacted by those changes. We are continuing to collect data on that. The way our system was set up before, we just did not have good insight into that. But over the last couple of months, we have done surveys with providers that serve individuals where legally responsible individuals are providing care. We have also done surveys through our care managers so that they can be reaching out to families and collecting information and then submitting that information to us so we can make sure that we have as much information as possible on that. So I don't have the final number on that to share, but we should have that pretty soon, kind of that compilation of data. So we did the provider piece first. Now we're working through with the care managers. We've gotten a lot of really good information, but it's not complete yet. So once we have that complete information, we'll have more data to share there, more details.
And for those of you guys that are not aware, attendant care and structured family caregiving providers beginning March 1st were required on their claims to begin submitting legally responsible individual information. So that should be fairly concrete.
Yes, yes.
In terms of getting through a first month of billing or so forth. And
yeah,
I haven't seen that detail.
Yeah, so that's another area where we're doing everything we can to try and get quick visibility into this. So we have data on the number of individuals impacted and especially those families we need to make sure that our care managers are working with for this transition to structured family care or to a different attendant care provider by July. The other thing I can share on the transition for attendant care to structured family care, we are working on going through expedited approval to get providers that provide attendant care today into structured family care. So one of the items highlighted before is making sure we have enough structured family care providers to provide services to individuals that choose to transition to structured family care. So we created an expedited approval path for those providers. We kicked that off a couple of weeks ago. So far, as of Monday, we had about 70 or so that had already been approved. I think as of yesterday, we're up to 100. And then we've got a little over 200 more already in the queue for approval. So we are seeing a lot of providers taking advantage of that expedited path, which is what we want. So we'll continue to reach out and encourage providers that we do hear from to go through that path and become enrolled. We do continue to get questions from attendant care providers and other providers, and we're working to answer those as quickly as possible as well, so they can make informed decisions on the path they want to move forward onto.
As a provider of SSC, I would be remiss if I didn't say I'm really concerned about the expedited process and the not meant to be negative, like the lack of oversight.
Okay.
Of those SFC providers, because this is SFC is not attendant care, as you know.
Mm-hmm.
And I think just watching and monitoring the FSSA webpage, you know, there are people that are in there that are just asking questions about, they're ridiculous, quite frankly. I mean, they can't even say structured family caregiving correctly, you know, and are interested in becoming a provider. So I'm really concerned about
I'm sorry, go ahead.
About that oversight going forward, that we're going to have 300 providers in the system.
So I will say the expedited path is not waiving requirements for structured family care providers. So we do still require them all by July 1st to have all of the components in place to have any trainings completed and have a good understanding of what structured family caregiving is. We have dedicated particular staff to making sure that as soon as we get one of those applications, we're processing them as quickly as possible. If they have all the documentation and all the information that they've submitted and are supposed to submit to become a structured family care provider, then we can move them through that process quickly. If they don't have that information, then we can reach back out to them and get through those steps as well. So we're not waiving requirements. It's just we're trying to move through that process because, you know, traditionally our enrollment process has taken a little bit of time with Division of Aging waivers, mostly due to staff bandwidth and making sure we get all that documentation from providers, and it can cause kind of a lengthy time frame for that processing. So we're trying to make sure that we're prioritizing that, understanding, you know, we've got a July time frame to get folks into structured family care.
So these are going to be state certified structured family caregiver providers, not just registered.
So structured family care providers are not required to be licensed. They are certified as waiver providers, like many other waiver providers are today.
So it's not just registered, not just give us your name, you're doing.
No. There's a certification process that they have to go through to make sure that they meet all of the requirements to be a structured family care provider.
I just think my concern is the oversight after
Yeah.
the fact, that this doesn't just become a means of pass through where there's not oversight
Yeah.
on the education requirements, the coaching requirements.
That's why I brought up the certification.
Yeah.
Yes.
Versus just a registration.
Yeah, and I will say that that oversight piece ties to the waiver transition as well. And so, there's lots of components that we're putting in place with Pathways and with the health and wellness waiver, because ultimately these providers, they're transitioning out of the Division of Aging and out of our current oversight structure into Pathways, where you'll have the Medicaid oversight and the managed care entity oversight. And then with health and wellness, you'll have still the Medicaid oversight and the Bureau of Disability Services oversight. And both of them have very robust provider oversight functions. And OMPP in particular, we've been working with them on a provider enrollment tool that they're standing up to handle the HCBS provider certification process too. So I think we're putting ourselves in a good spot, but your concern is understandable. And I think if you hear things if you hear things from individuals, if you see anything concerning with any new providers, please don't hesitate to reach out to us so we can address that as quickly as possible.
Thank you, Leslie.
Yeah. Okay. So the next update on the Medicaid forecast strategies, service plans. So I just wanted to highlight another strategy that we're enacting. A part of this is from a compliance standpoint as well. I think trying to set some of the compliance standards for the waiver, but we're doing more proactive reviews on service plans. So in the past, we had a certain number of service plans that would go through an auto approval process. We have pulled back some of that and have brought on additional team members to help with service plan reviews to make sure folks are getting the services that they need, the services and the service plans and how they're being provided are in alignment with the waiver definition, and trying to track items where additional training would be helpful both for providers and for care managers as we are taking a closer look at some of these service plans. Part of that too has involved starting bi-weekly trainings for care managers in particular so that we can start providing them feedback on on the various Medicaid forecast strategies, but also just different items that we know as we're going through all of these different processes to make sure that we're providing them guidance and education and feedback, and they also have an opportunity to ask us questions on things that come up as well.
Leslie, what was the third service? I mean, the oversight, the additional oversight is on structured family caregiving, attendant care, and HCA.
Home and community assistance is another one that we're looking at because it is very similar to attendant care. Yep. And so the last Medicaid forecast item that I wanted to update on is tied to retroactive eligibility. And this is more just to highlight, we will be issuing FAQs here pretty soon, just providing more information for providers and consumers on what that means exactly. Because I think it sounds really technical for folks and just want to make sure that we're being clear with everyone on when we say no more waiver retroactive eligibility, what that means and what that doesn't mean. So those FAQs should be coming out here pretty imminently. We're trying to get those finalized so we can get those out. And we've got systems changes that will be in place here soon to prevent those from a case management system perspective from occurring. So we want to make sure we get that guidance out before that takes place.
Are the waivers closed for this year? We had some discussion of that last time and we're running out of money.
They are not closed. We are monitoring the slots available in the waiver. So the number of individuals who can be on the waiver for any given waiver year. So we do continue to monitor that and are building in different processes so we have more real-time information on that. So we'll continue to monitor that. Any updates that we have to share on that, we will send out via listserv and through our Medicaid strategies webpage, which was the last thing I was going to mention is always happy to share information, but that webpage is the source of truth. It is where all of our guidance is getting posted. It's where all of our announcements will be posted. So recommend continuing to monitor that webpage just to keep up to date. And if you have questions, we're working to get information on that webpage in particular to make sure folks have a resource to go to get those questions answered, hopefully.
But the waivers are not closed.
They are not closed at this time, correct?
But we are in the window that was mentioned, late March to early.
Yes,
April,
we are
so,
in the
yeah.
window that was mentioned, so that's why I'm asking the question.
Yeah.
We Probably
good
are
news.
pretty close.
We, as soon as we have any information to share on where we end up with that, I will share it out. You know, we're, like I said, we are monitoring it and we've got a lot of folks on the waiver today. We are adding additional slots effective July 1st as well. That had been part of the plan, as well. So,
Yeah, we
We're
know
just- we're
that. We
watching
know
and
there are probably
see.
not enough slots for the next year, but.
we watch and we see, and it's one of those things that's why we're working on more real-time visibility into some of this too, to make sure that we're tracking it, because it is, you know, getting folks enrolled. It's a complex system because it ties to financial eligibility through DFR and functional eligibility. So we're doing everything we can to make sure we're monitoring it as closely as possible. And as, you know, once we get to a point where we feel like, you know, we may have to implement a wait list, we'll share that information out, share guidance out, and do everything we can to support families, support the AAAs, support providers with that.
Well, my point being not a criticism of what you're doing, but actually for public education literacy on public policy. I mean, I know we have, our voters are quite tax averse in Indiana, and yet Medicaid is funded through general tax revenues. So people don't understand that Medicare does not take care of long-term care. And so anything that we can do to help the general public understand, if there aren't cookies in the cookie jar, you're not going to get services. So if we continue to just talk about tax aversion strategies and then people want services, that doesn't work. I mean, the Division of Aging and OMPP doesn't have they're not a fairy godparent out there just handing out money. So, you know, I think the general public, there's just a lack of awareness, good salt of the earth people not understanding how the funding mechanisms for for both acute care and long-term care are structured. And I don't know, it's very hard to get accurate educational material out there for people to understand this. So that was my point, not a criticism of what you're doing, but a fact that, you know, we do have a literacy problem around public policy on these issues. I don't have an answer for it, but I think we need to bring it up and discuss it, because people just get frantic when there aren't services. And that's why I brought up the waivers closed. I mean, you can't make something out of nothing if there's nothing there, but people don't understand. So I think it behooves all of us to try to think how we can help the general public better understand this. It'd be lovely to get something for nothing, but that's not real. So that's my point here. So thank you very much, Leslie. Do you have more to share? Or are there more?
Not on the Medicaid forecast unless anyone has any additional questions. Okay. So I will pivot to our general aging update. So a couple of just things in the pipeline through Division of Aging that I wanted to highlight. One that maybe perhaps Dr. Burke ties to a little bit of what you've highlighted, our multi-sector plan on aging. So I know you've probably heard us mention this a little bit over the last year or so. So we are finalizing, getting a kickoff meeting on the calendar later in the spring, targeting May as Older Americans Month. We felt like that was appropriate. So we'll have more details to share on the multi-sector plan and the kickoff meeting and all that information prior to the May meeting, and in the May meeting itself, we could provide a more robust update, but just wanted to highlight that we're just about there. So we're really excited to get that work kicked off. Our goal is to, you know, create that long-term plan that really supports aging Hoosiers over the long term, and hopefully be more proactive on some of these different issues to make sure that we're ready for that increased aging population as it continues to grow. So I just wanted to mention that and highlight that you'll start to see more information on that coming out here before the May meeting. The couple other things I wanted to highlight. So the Dementia Care Specialist Program, you might remember that there was a bill passed last session to implement a Dementia Care Specialist Program in partnership with the area agencies on aging. And so that is intended to be an education and outreach program regarding dementia services and supports available here in Indiana. So we are in the final stages of getting that kicked off as well. The contracts are going through the process. We shared budget information for the AAAs, and I know a lot of them have started started actively hiring for their dementia care specialist positions. So we are really, really excited for that to get kicked off as another support for individuals with dementia and their caregivers, especially. We think it'll be a really important initiative that we're, again, very excited to get moving in collaboration with the other dementia work that Division of Aging is involved in the state of Indiana as well. Part of that too will be hopefully measuring some data on outcomes for that program so that we can have some visibility into hopefully the benefits we see from it as well. Tied to caregiver supports, there's another initiative that I wanted to highlight and maybe suggest a presentation at the May meeting if you all are interested. There is a new app for supporting family caregivers called Caregiver Way that was developed by Joy's House and was just launched last week. It was developed partially in support from Division of Aging and some of the additional COVID funding that we had available. So I've seen some versions of it, and it is really just really impressive and has a lot of really great resources for supporting family caregivers, everything from practical advice and videos on how to help care for your loved one to forums and journal options and access to different individuals who can offer support, to information on life after caregiving, which I think is something we don't talk about much, which is critically important too. So it's Caregiver Way. Yep. So if you're interested, happy to help facilitate a presentation on that in May. I do think it's something that's just a really great development that would be good to understand and highlight. So just putting that.
Katie, you're on. I would say yes to that. Are you in support? You're our presentation person.
I'm in support of that, Joanne. And that was May?
Yes.
Okay.
Great. Thank you.
You're on.
All right, we will
Thank
do
you.
that.
Thank you.
Yeah, thank you. The last item I wanted to highlight on developments for Division of Aging is we have hired a legal assistance developer. So this is a position required under the Older Americans Act. Historically, the Division of Aging has had that position kind of wrapped in with a couple of other positions. We hadn't had a standalone person that did that role. And so we have hired one, and his name is Bill Lutz, and he's actually here today. But he started this week, so don't pepper him with questions yet because he is still getting up to speed. But we're very excited to have him on board. One, obviously to meet the requirements of the Older Americans Act, but also really, he's got a really great background and experience in working with older adults on a variety of legal issues, including Medicaid and waiver access, working with the AAAs in different ways too. So he's going to spend some time getting up to speed on all of the legal assistance programs around the state and just get the lay of the land on things. But we're very excited to have that position on board with the team. Those are all of my updates. Does anybody have any questions on any of that or anything I didn't mention?
Can you just a little bit further about that role? Is that working directly with consumers? Is that working with providers, the AAAs, or?
Yeah, so at a high level, it's intended to kind of be a coordinator role a little bit, right? So having an understanding of the different legal assistance programs available around the state to support individuals, but can be also used to kind of point out gaps in services available and work with different community resources to kind of fill those gaps. It can be education and outreach across the state as well. So like I said, we have not really had a dedicated position for that in quite some time. So part of Bill's job is to also think about what should this role be in Indiana and what makes the most sense to support that. So I know that's kind of an amorphous answer, but that's
No, I
sort
think
of
that's
the initial
great.
intent. Yeah. Okay. Well, thank you very much.
All right. Well, thank you for your update, Leslie. Good to have you back doing your presentations. Thank you. We appreciate it, Andrew, but good to see you. Okay. Dan, I think we're ready for your presentation. Dan is chair of our Housing Supports Advisory Committee, and they are giving a presentation today.
And first of all, thank you to Rebecca and Julie and Ted for working out the technical issues. Anytime we have someone who comes in and presents at Millrace Center down in Columbus, where I'm the director, it's always my pet peeve when they come in not prepared to have their presentation set up. So There were some technical things that were going on, but we got it worked out. So thank you to those three, especially for helping this. So I am not an expert on housing. It is not my background, but as a member of the commission, Dr. Burke asked if I would be willing to chair a subcommittee that would take a look at housing in Indiana, especially housing with supports for older adults. And I thought, yeah, we can do some problem solving. We'll get this thing fixed and wrapped up and, we'll be done. Obviously, I was very naive in that regard. It is a much bigger issue. And events in the last year or so really brought it home to me. My parents both passed away last year, but they had lived in their home up in Michigan. And so a lot of this became very real when I realized the challenges that people have of aging in their home. They lived in an old farmhouse that was probably not safe for anyone, but especially someone who was at that time 91 years old. It was not an accessible home, and even just the throw rugs in the house presented hazards. So it was a miracle that they were able to live there as long as they did. And it was only because they had a village around them of people who were willing to help them out to stay in their place. So it's obviously an issue, and it's an issue that cuts across pretty much all income brackets. It's not just an issue for older adults, but it really spans the whole community. And so as we dug into this, it was something that we realized this is something that is not going to be solved easily, but we were able to at least pull some information together and have some discussions. And then my role then was to bring that back to the commission. So our statement of purpose early on was that the committee would explore options for affordable housing with supports for older adults in conjunction with Indiana's transition to managed long-term services and supports. Housing models will reflect the belief in the provision of care in the least restrictive and safest environment, while empowering older adults to enjoy maximum independence. And then, as I said, we would bring some information back to the commission to help educate other commissioners who, like me, might not be experts in housing, but would at least have a better understanding of some of the issues that we face. So our initial discussion, next slide, please. Our initial discussion would be, who should be at the table? And we still don't have everyone probably who should be at the table to have this discussion. And we will continue organically to kind of grow. And most of the folks who became members of the subcommittee were recommended by other people. It's like, oh, who needs to be here? It needs to be, Heidi or somebody else that needs to be part of this group. We also wanted to identify some of the current barriers, whether that was staffing or accessibility or transportation. Who is currently doing the work? We wanted to know who were some of the groups and some of the entities that are already looking into this. And the good news is there are a lot of really capable folks who are taking a look at this right now. Communication and collaboration might be a barrier, but at least there are some folks who are doing the work. Are there other states who are doing this well? The short answer is no, everybody is. There are some states who have made some strides, but for the most part, everybody is struggling with this issue across the board. What are some potential models, and how would they be funded, or how are they funded? And what type of gap programs can be implemented quickly to address critical needs, and what can be implemented at a later date? So next slide, please. Some of the members of the subcommittee, we tried to reach out to folks who come from various different backgrounds, and it might be a little hard to read. I will read the names. Heidi Ewan, who is with the University of Indianapolis, and she has done really extensive research on senior housing. So she was a tremendous resource. Lori Phillips Steele, who is the director of the Corporation for Supportive Housing. Jennifer Lance, who is a fellow commission member. Kristen Lais, who has been really a wealth of information. And since I'm not an expert, if anybody has questions, Kristen will be happy to answer those for you. Hale Crumley with Prosperity Indiana. Mark Lindenlaub, who is not only the executive director of Thrive Alliance, which is Area 11, the AAA in Bartholomew and surrounding counties, but he's also the director of housing partnerships. Britton Brewer has been a really fabulous resource. He works with the IU School of Architecture that's based in Columbus. and Andrea Davis, the Executive Director of Hand Incorporated, Jamie Zobrist, who is the Executive Director of Just Friends Adult Day Service. And she has had a lot of really useful insight into folks who are living at home with supports and receiving services and what that looks like. It might be a little bit different than our experience in the day-to-day. And then most recently, Jennifer Trowbridge, who is with the Northwest Indiana Community Action Housing Opportunities Group. And we had a conversation offline to try to get some updates on what she has been working on. So next slide, please. So the task of the committee has been to raise awareness regarding the need for affordable senior housing and why there is such a sense of urgency due to the aging of baby boomers. Also to support local zoning advocacy to enable multi-generational family dwellings, including secondary residences, call them accessory dwelling units. Sometimes they're referred to as mother-in-law quarters. There are, depending on the community, some communities have regulations already in place and provisions for variances in zoning to allow them. The city of Columbus, where I live, they've had something in place for a decade. Other communities don't have those zoning variances available. The other issue there is a lot of homeowners associations will not allow them. So that could be an issue. The work also needs to be inclusive, and it was a point made by several of the members of the committee that we need to address the needs of all older adults, not just those who are currently eligible for Medicaid services. So when we take a look at, next slide, please, take a look at some of the groups that are doing the work currently, who is taking a look at housing. Obviously, FSSA has a lot at stake in the question of housing as we transition to home and community-based services. OMPP, the Indiana Department of Health, Indiana Housing and Community Development Authority, IHCDA, have provided a lot of information and have done some tremendous work in just seeing what is available and how policy should be driven. The Indiana Association of Area Agencies on Aging, especially with Kristen Lais being part of this group, has been a tremendous resource. Prosperity Indiana, the Environmental Resiliency Institute, the Office of Community and Rural Affairs, Center for Aging and Community, the Indiana Legislature's Housing Task Force, the Corporation for Supportive Housing and Northwest Indiana Community Housing or Community Action and Housing Opportunities. So there are a lot of groups, and that's just a partial list. There are a lot of folks at the local level and regional level who are also looking into this issue because it really does impact all of us. So let's take a look at next slide. Some of the challenges that are out there in this shortage of affordable and accessible housing. The current estimate is that there are about 6,000 housing units needed, and even that number is kind of a best guess. Depending, my parents might not have showed up in any research that was done because they were living in their own home. Was that home the safest environment? No, absolutely not. But they were managing. And so, the number is probably much greater when we take a look at how many people are living in housing that really is not the best solution for their needs at the time. So I would say that the number of housing units that are needed is probably a very low estimate. I'm sure that it's much greater than that. And I reached out to Deborah McCarty through Mark Lindenlaub with Housing Partnerships in Columbus. And there's a kind of a recurring theme here, which she was looking at low-income housing tax credits and how that can be applied to property development. She said that there was, once incentives were included to make more units available that would be wheelchair accessible, they saw a significant increase, right? So incentives will be kind of a recurring theme here. And some information that came to me even last night kind of bears this out. Next slide, please. Just continuing the idea of income levels and inventory, Jennifer Trowbridge provided some information saying that 40% of the households that are 65 and up have incomes of less than half the local area median income. The unhoused population is also aging, and the number of unhoused elderly will double by 2050. And the health of older people who are unhoused is deteriorating at rates that are much faster than the general population. And the affordable housing for elderly folks is not keeping pace with the demand, which is something I think that we all know. Next slide, please. One of the challenges that we have right now is just the trends in new construction. I'm not picking on anybody. That house, although it's not my house was built with the exact same floor plan. So in 2017, my wife and I were looking to buy a home. And part of our conversation at that time, I was 57 years old, and we were looking at aging in place. I mean, that was something that we were considering. That was a discussion for us. And so we were looking for a single-story house that the laundry room would be on the first floor. I mean, all those things that you would think about if you were preparing to try to age in the community. And every time that we found a house that might meet that criteria, we would go to make an offer. We'd find out that somebody had already made an offer on that house above the asking price. And I mean, literally, we would call, or we would be with our real estate agent, and we'd say, yeah, we want this house, make an offer. And they go, it's already sold. There were no houses available that really even fit that bill, especially the ones that were in our price range. So our option was to build a home. And this was, you know, obviously it's a mass manufactured type of builder that built this. And if you drive up and down I-65 or most of the main roads and you look at any new subdivisions, that's the format. Basically what we're doing is we build cubes because they can be built on the smallest footprint. The lot can be fairly small. And you can get, you know, more square footage by building up instead of building out. So that's a huge barrier in the building industry because property is the real expense. Last night, I went to a meeting in Columbus, and the city there is contracting with some folks to come in and do a study on housing. So it was very timely. And I happened to be divided up into a small group of people, just kind of organically. I didn't know the folks. There were 3 builders and 4 real estate agents that were sitting in my small group. And they all basically said the same thing. You know, the problem is the cost of lots. A lot in Columbus right now is about $75,000. So if you build a house and if you have to have a lot that's big enough, it makes it prohibitive to try to build anything that's affordable on a single story. And everybody seemed to be agreement on that topic. And so, you know, that was something that was discussed as part of the larger group. So what are the results of that is, I know even at my age, and I'm mobile, but if I had to have a knee replaced, it means I'd be sleeping on the couch on the first floor and bathing in the kitchen sink, because there's, you know, the full baths are on the second floor in all of the bedrooms. And that's pretty typical. When we look around at most of the new houses that are being built, that's the model. So it creates a real barrier because if folks have any kind of accessibility issues, that is not going to be the place where they can live. So we knew going into it that at some point we would have to sell that house and move one more time to find a place that would be accessible. Next slide, please. So we look at some of the preferred solutions that we have discussed. One of the things that's really missing in this discussion is to try to bring home builders and landlord associations into the conversation. I don't think we can make much progress without them being at the table. They have a very significant voice in Indiana's legislature. So I think we need to create a collaborative environment to work with builders and landlord associations toward a solution. This will require incentives to prioritize or incentivize new accessible housing and renovations that will be conducive to aging in the community. Zoning considerations would need to be addressed to allow accessible single-story dwellings when developing neighborhoods. And the 3 builders all said, one of them specifically has entered the market. He had done some other work and now he's come back to building. And he said, I want to build affordable homes. I mean, that's his mission now. He has kind of made his money doing other things, and now he wants to build affordable homes. And he said, the barrier is the cost of lots. And he said, without, in this case, the Bartholomew County and the city of Columbus, without them doing something to assist folks in purchasing lots and bringing down the cost of lots, that'll be very prohibitive. He said, margins are thin enough already for builders, but if they're trying to build something on a single lot, that would be single story. That will be the barrier. This is the cost of lots. We would also like to advocate for stronger rules regarding conflict of interest and recusal for legislators. That is an issue right now. I believe that there are a lot of folks who do have vested interest in both being landlords and builders, but they are not required to recuse themselves from discussion of legislation. Recently, the Notre Dame Clinical Law Center took a look at eviction laws and renters' rights in Indiana. So this study just came out last month. And their finding was that Indiana falls short on most of the American Bar Association's guidelines for eviction laws. Indiana currently ranks very poorly in renters' protection. So that's something else that I think would need to be looked at as a group, as a state, and figure out some way that we can do that. Next slide, please. We have discussed workforce in a lot of different ways. There are a lot of initiatives right now that are taking a look at how we develop a skilled workforce. And it's, I'm sure all of us are concerned about moving into community-based settings and where are we going to find the folks who will be qualified to provide in-home services. That is really, really, I think, a big fear of most of us as we make this transition. Where are we going to get the people who can provide the services? I'm going to take off my hat as a commission member and just speak as a concerned citizen that has a background in disability services. I have a lot of colleagues in disability services who are really struggling to provide staff in their supported living homes or group homes. And my concern is that as we transition to home and community-based services for older adults, if there isn't parity in funding between those areas, that it could be that better funding would be available to older adults to make the transition happen. And that folks who are currently working in disability services would have incentives for leaving their work and going over. Because we have to remember, most of those folks are fairly low income who are providing those services. Reimbursement rates are such that it's difficult to even pay a living wage. And 50 cents an hour or $1 an hour difference would be enough to make some folks leave the field that they're in. I know some of my former colleagues who are working 80 hours a week because they have to step in and help staff some of the homes where they don't have enough staff. Next slide, please. The subcommittee supports the findings and strategies that are outlined in the state legislature's Housing Task Force report, although the task force did not specifically address the need for in-home services that would enable more Hoosiers to remain in community-based settings. It was a little bit outside of, I think, the scope of that particular study, but I think that those two things have to go hand in hand when we're taking a look at home and community-based services. Next slide. We would like to encourage OMPP and the Division of Aging to continue to explore the expansion of Medicaid waiver funding for housing. And I know that there has been some discussion of that. Typically, the model right now that is within disability services is that folks split rent in a supported living home. They split the rent, and then the waiver will pay for the services for staffing. But there is no funding available right now for rent. And so perhaps that's something that could be considered. Next slide, please. When we look at some of the potential models, purpose-built accessible housing, single and multifamily dwellings, and that really needs to be probably tackled at the local level. And as I said, in Columbus, that's something that the city is looking at right now. And a lot of those decisions probably need to be made at the local level. And, is the city willing to take some of its property and make it available for low-income housing. There were two themes that came out of last night's discussion that we had, and that was the need for universal design houses, because most of those homes not only are suitable for older adults, but they're also suitable for young families. Any time that a house is accessible, it helps everybody. But in order to do that, again, we have to address the cost of property to build those. The second was, how do we support folks who are unhoused in the community? And I know in our community, especially, we have seen a significant increase in the number of people who are unhoused. And so, that will also be an issue. So really it hinges on affordable housing. The most recent construction that I have seen in Bartholomew County and in Columbus has been, for the most part, high-end senior living communities. We did build within the last few years, last 5 years, one housing unit. It's an apartment complex that does accept Medicaid. But for the most part, they're pretty high-end exclusive structures. So, that's an issue. The most recent apartment building that opened in Columbus has apartments that are $3,500 a month. So, the biggest concern that folks had was that, we are a community down there that has some pretty large manufacturers, Cummins, Diesel, Toyota. There's several manufacturers. The people who are doing the actual day-to-day work, folks that work the lines, can't afford to live in the county. So they're moving outside of our county and they commute to the jobs. And the folks who are kind of middle and upper management live in the community. So they can afford the $3,500 a month rent for an apartment. But the folks who are actually manufacturing the parts and pieces and putting the engines together can't afford to live there. The other model is to repurpose existing structures. The Armory in Columbus is one example of that. It was an old building that was converted into apartments, and it's a great way to preserve existing structures, but to repurpose them. And then the idea of residential cooperatives, especially around naturally occurring retirement communities. And that is happening in some areas. People live on a cul-de-sac. They're all about the same age. They bought their houses at about the same time. So they make an informal agreement that they will share and have somebody come in and do home health care type visits. They'll get Meals on Wheels, and they'll just continue to live as their own little mini community around some naturally occurring supports. Next slide, please. When we look at some more potential models, we mentioned supported living, which is currently the BEADS model, where roommates share living expenses and then the waiver pays for support for services. And I would offer that it may be that folks would not necessarily be able to live in their own home, but they could live in a home in the community and share the cost of housing with 2 or 3 other roommates, and then pool resources and be able to have staff that could support more than one person. I think we need to be careful with our language when we talk about people who, we have changed the language somewhat to aging in the community. We quite often, though, will still fall back into the language of a person aging in place. And I think that carries with it the possibility that a person can stay in their own home. I'm not sure that is going to be economically feasible where everybody gets to stay in their own home. But we can possibly develop a model where people can stay in their community, which might be second best. Another potential model is multi-generational cohabitation. This one is a little sketchy. I know there would have to be a lot of oversight. But in some communities where you might have, a college, where folks need a place to live, that would be affordable for them. So pairing younger folks with older residents who can form some shared informal supports. And then accessory dwelling units, we spoke a little bit about that already, but that would require appropriate zoning. So in this case, having not necessarily somebody under the same roof, but at least having a small dwelling on a person's property, whereas an older family member or loved one could could actually be with them so that you could keep an eye on them. And the next slide is just a graphic that is available in Bartholomew County, and it's talks about how to go about the process of getting variances for zoning to be able to, there you go, that's the one. Some examples of tiny homes and how they can be used in the community. And there have been some areas, I know Austin, Texas is one community that has done a good job of kind of developing communities of tiny homes to address entry-level housing for folks who are low income, and also for people who are unhoused, that it's a kind of an efficient way of doing that and developing small communities. And you could even have, you know, a post office in areas so that folks who had been previously unhoused will have access to an address and some other services available, but still have a space. I know in Columbus, one of the issues we have with our homeless shelter is that it's still segregated, so couples aren't able to stay together in the shelter. And so, you know, that creates an issue. So there are a lot of folks who choose to, even through the wintertime, we had people living in tents because they were a couple and they didn't want to go to the shelter and not be able to stay together. So, you know, that's something else that probably needs to be addressed. So last slide, please. So just one final thought that I would share is that work of this scope, and obviously this is something that impacts everybody. At some point, if we're all fortunate enough to enter old age, you know, we will have probably making some decisions about the place where we live. So this is something that really has a universal impact. And what happens when you're trying to tackle something like this is that the work often becomes fragmented, or it'll take place in silos. And so it's our hope that the various groups who are addressing the issue of housing for older adults will continue to share information and work collaboratively towards solutions. And if the Commission on Aging can help facilitate some of that collaboration, I think that would be you know, a worthy goal for us to be able to do, to pull folks together and have that information shared across some of the silos. Any questions? Kristen will be happy to answer them for you.
For a non-housing guy, Dan, that's pretty amazing
Yeah.
work that you've been.
It was like drinking from a fire hose, let me tell you. There were a lot of really, really knowledgeable folks who shared great information.
Really fantastic. I had a follow-up question, if you wouldn't mind just going back, when you were talking about the parity in rates. Can you say a little bit more about that, like what your concern is?
My concern is that in order for the transition to be effective, that there might be some additional funds made available, and especially, you know, perhaps higher reimbursement rates. And I'm not sure, that's just me speaking without knowledge about, you know, what those rates might be. So that if the reimbursement rates were higher for home and community-based services for older adults, just to help the transition happen, that it would then potentially incentivize people who are currently working in disability services to go to other providers that might be paying more.
Okay. Okay.
And maybe you left us speechless. How about that?
That was really remarkable, Dan.
Thank you so very much. Now, you know, when we put these advisory committees together, we just kind of guess the topics that we're going to need to really be tuning in on here as a commission. Now, I'm going to step forward and say something. Obviously, housing's one of these, especially as in Indiana, I use this word, we're deinstitutionalizing the care of some of our older adults with very high vulnerabilities as we move, and I'm not saying we shouldn't do this because we've got to do this, move from Medicaid paying for 75% of the nursing home beds to 25%. It's not going to happen overnight, but there's an assumption being made that people have a place to live. They're not in a nursing home. And we're a bit challenged right now with inflation and the cost of housing, et cetera, et cetera. So that we've got a gap there that we haven't addressed the cost of housing for these people and where they're going. So as a division on aging moves to the I hope I'm using the correct terminology, their multi-sector plan on aging. We know housing needs to be part of what's going on, so I'm asking that this housing advisory committee continue to work in an advocacy way with the Division of Aging as they bring up issues in the multi-sector plan on aging. And that'll be true of our other committees too.
Yeah, and the realtors and the builders that were at the meeting last night, I was surprised that they all seemed to be on the same page, and somebody made the comment, there is no free market solution to this issue. If we're leaving folks up to the fact that you can only build from a profit standpoint, it's going to be very difficult to do that. There needs to be some involvement, even at the local level, of either some incentives for that or some subsidies to help purchase lots. It wasn't the building of the building, it was the purchase of the lot that seemed to be the big barrier. The other issue that we're facing is that when we deinstitutionalize folks with disabilities starting in the 80s and then going through, a lot of the homes that were accessible, that were available on the market, were purchased to be used as supported living. And so a lot of those homes are now occupied and it's an amazing way to use those homes. But the inventory of that house that was easily accessible has been kind of used up. And so there aren't a lot of new homes that are being built that would also serve that purpose. So that's going to be an issue of just, where do we find those homes? Now, I know one landlord in Columbus that owns 100 of those houses that are Medicaid waiver homes. So, from a landlord standpoint, it's great. And she does a fantastic job of maintaining them and keeping them up to standards. It has been a great solution, but it also removed a lot of homes from the inventory.
Well, we're in a state that loves a free market, but there is a role for government when the free market's not going to provide the solution. And we need to advocate for some looking at this, because we are putting people out of what they were housed in nursing homes. And now we're changing direction and we have a gap. So thank you so much. And we will keep looking at this as the commission. This is what we are by statute are supposed to be doing. So we will. May not be popular politically, but I mean, it's an issue. There is a role for government to step in when the free market's not dealing with something. So you very clearly put that out. So thank you so much. Any other comments on this? Okay, very good. All right, we'll move to advisory committee reports. As I said, I'm kind of just sitting. I will say, in terms of working with local communities, again, I encourage everyone to, as you can, work with your local communities. We did get zoning changed in Little Tipton, Indiana, and we now have approval for accessory dwelling units. Now, I would say one has to look carefully to be sure that the requirements are not so onerous that it's impossible to do them for the working class families, but that was passed. So it is, if we can do it there, we have a lot of challenges in some of these rural communities. We did manage that. But I think what you put forward with I guess I shouldn't use housing with supports in the disability community, it's congregate housing. And I don't know what happens when you apply for Medicaid and you're in one of those situations where you're sharing rent. I guess you're paying rent for a room and partial use of the kitchen or something, but I don't know how that goes. But anyway, there's a number of things we need to continue to look at as we look at local communities and our work with that. Okay, Deb, do you have anything from emergency housing you want to comment on? Deb may be off the call right now.
No,
Kelly.
I just, I'm technologically challenged. I couldn't figure out how to unmute myself. So, hello from sunny Florida. I'm doing a little bit of housing research down here at Naples. I'll continue to do that for the next several days. Yeah, actually, so we have a memorandum of understanding. We're going to do the pilot in the Fort Wayne area, and it serves 9 different counties up there. And I have a phone call tomorrow to kind of do another once over for the memorandum of understanding. But my next step is to get in touch with nursing facilities and assisted living communities in the 9 county areas and kind of get a working list of places that would be open. And we really see it really more like transitional housing. Not everybody's solution is going to be long-term care or assisted living. It's more, we've got to get them out of whatever emergency situation they're in and get them in the least restrictive environment that's the safest for them at that moment in time. So that's kind of where we are. And of course, I guess the APS is going through some restructuring or something at the state level. So, it's kind of like you hit on the gas and then you tap the brakes, and then you hit on the gas and you tap the brakes. So there's some things going on from APS's side that they just have to make sure certain things are going to happen certain ways. But we're hoping to get this thing started maybe by July.
Okay, thank you very much. And we certainly will be interested in hearing more about that initiative. Thank you, Deb.
Yes.
Kelly?
Yes, Dr. Burke, thank you. So we were able to have the first meeting of the Family Caregiver Support Advisory subgroup of the Commission on Aging on March 12th. Really excited about the diverse participation that we have. We've got representation from AARP, we've got the Alzheimer's Association, a lot of representation from current AAA leaders or former AAA leaders, assisted living, PACE providers, so really broad scope of participants. And ironically, just heard from Tina McIntosh yesterday that she's going to be joining that subcommittee as well. So super excited to have her joining us with all of her expertise. So really the first meeting was around agreeing on the scope of the committee. And I'll just share what we defined as the scope, and certainly welcome the Commission on Aging's feedback on that. So first is examining the family caregiver resources and supports available for nursing facility eligible and community well caregivers. Assessing the impacts of programs, policies, services, and awareness campaigns aimed at family caregivers. New and part of our conversation was engagement in the governor's multi-sector plan on aging. So it's interesting that has come up on a couple of occasions today. And then, of course, advising the commission on opportunities to close gaps for family caregivers in their knowledge, competence, and awareness of accessing support services and resources. So again, welcome any feedback from this commission on kind of the scope of the work. I will say we really spent the first meeting focused on the transition to pathways and the health and wellness waivers and impact to family caregivers of individuals receiving aged and disabled waiver services. We also had some robust conversation on the changes to legally responsible individuals and the impact to, in particular, parents of minor children and spouses that are currently being paid attendant care as paid attendant care providers. So a lot of conversation on that. Many of the things that several of the things that we talked about around issues identified as part of that first group, we've talked about here today. There was a lot of concern expressed about whether or not FSSA has been doing a good job of educating individuals on all resources, all long-term services and supports available to them outside of pathways. And so I think that was addressed here today, talking about that, because in particular was the concern that Maximus may not be sharing at this time the availability of PACE as an option. So I appreciated, Kim's and Holly's comments on that earlier today. I'll be able to take that back to that committee. There were questions about whether or not FSSA would be reporting out on the number of contracted providers with the health plans to ensure network adequacy, which is another thing that we talked about today. And there were just a couple of concerns as we talked about in terms of the messaging delivered by Maximus to some of these families who had made contact that they had heard from family caregivers. So again, you know, I'm happy to hear that the state is addressing that they're taking the concerns that are raised to them seriously and doing ongoing coaching and education and training with Maximus. There was one question that came up that no one seemed to know the answer to, and that was what will happen to QMB eligible Medicaid recipients through this transition to managed long-term services and supports? And I'm not even sure where to address that question or
I will take that back to the Medicaid team so we can get it addressed. I believe they are carved out because it's a limited eligibility category, I think. So,
Okay.
But I'll double check that and we'll make sure we get that
Okay.
too.
Thank you. So I then subsequently just requested some feedback on how frequently the group felt that we need to meet. And initially, we're going to start on a monthly basis, and we'll get through kind of the pathways transition. That obviously will not be the sole focus of this subcommittee in terms of focusing on family caregivers, but it is something that's very top of mind for everyone right now. So, and those are my updates.
Okay, any comments, questions from anyone? Okay, thank you so much, Kelly. Another topic that of great concern. We are making progress in this state, though, on that end of things. When you're how, I don't even want to say how we ranked, but anyway, we had room for improvement. And we are improving. Great. Okay, do you have anything further to add, Dan, on supportive? Okay, well, then we'll turn it over to you for an update on Senior Center Coalition of Indiana.
Okay, just real quickly, we do have a regularly scheduled brown bag session for senior center leaders tomorrow. We'll be talking about best practices for homebound seniors. So a lot of senior centers have folks who, for whatever reason, aren't able to get to a location. And how do we work with the folks who are kind of part of our family that we serve, and how do we deliver services to those folks? And then our annual conference will be in Tipton again this year, and that will be April 26th. And the main topic of that will be burnout, basically, of senior center leaders and staff and key staff. It's something that I think most of us, probably most of us who work in senior services across the board, not just in senior centers, but how do we stay motivated and avoid burnout?
Okay, thank you so much. Any questions, comments to Dan on the Senior Center Coalition? All right, thank you so much. Kristen, how much time you have today?
Hey, what about me?
Hey, Judith.
Oh, wait a minute. Judith, I'm sorry. Oh, my apologies. Just a moment.
Okay.
I am so sorry, Judith. I skipped right down.
You did. You just ignored me. Two things.
Shared
First-
decision. Yeah,
sorry,
go ahead. Your turn.
Okay, for Dan, what our community did, which I was very, very proud of, what they did is we put a bill, ordinance forward that says that we can have a home, a garage, and an outside building. That could be a shed, it could be another garage, or it could be a tiny home for a person to live in. Because what happened was we had one of our firemen had a family member they needed help with. And so they put this ordinance out, it passed, so we're lucky there. And then the other thing was they bought a tiny house from Walmart, honest to goodness, $5,000. And thankfully they had the skills to put it all together, but they were able to move their relative in for a little over $7,000. That's a nice way to do it. And our community actually helped with that. So we've been lucky that way. As far as supported decision going, is we are doing we got permission to do a pilot program for a CASA, court appointed special advocate, in the court of guardianship. So we're working on that, and we've got a lot of people that are involved in that. It's APS, we've got the county commissioners. It's been crazy, but we're working on it, and we're still working on it. So as soon as we get a better handle on how we want to run it, that's when we'll get back to you guys.
Okay, any questions, comments for Judith on shared decision making? Okay, my apology again, Judith, but anyway. Okay, thank you so much. Well, that Walmart tiny house was kind of interesting too. So anyway, that got everybody's attention too, Judith. Thank you. Okay, Kristen, now.
Good morning, everybody. Good to see you all in person and virtually. I want to start by just really complimenting Dan on his leadership of the housing subcommittee. He kept that group together and engaged for more than a year. And as you can see, he's just so very thoughtful and very politic in the way he says things. Take a note, Kristen. So anyway, just really want to congratulate him on finalizing a report. And as you said, he's charged to keep it going. And I'm kind of not bearing the lead, but stealing my own thunder in that the bill that would add housing expertise in the form of IHCDA to the Commission on Aging and Choice Board passed. And in fact, the governor has already signed the bill and an emergency was declared. So they could have been here today, but I don't even know if they've been informed that they are now on the committees. So that will be something that we can look forward to.
Looking at Aaron.
in the
we'll
future.
have to-
Yeah.
Oh, okay.
So, we'll give, it's only been like a week since I think the governor has probably signed the bill. So we'll look forward to having additional expertise moving forward.
And this is from IHCDA.
Correct. And we'll talk a little bit more about that because I want to talk about the other positions that were approved as well. So, okay, it's coming. In your packets, I did include information that highlighted Senator Bro's contributions as a legislator, as well as her farewell statement, which came out earlier this week prior to her passing. And she was a significant champion for these issues that we advocate on. She was significant support and help for I4A in things that we have tried to move over the years. And she worked so hard. You know how complex this is. And legislators have to know everything, right? They're supposed to have some ability to vote knowledgeably on everything. And boy, did she ask questions and would revisit these topics every time there was, year after year, a new topic came up and we'd kind of do another tutorial on how it all worked. And she worked so hard to make sure she was a good advocate on behalf of older adults and people with disabilities. So, we will feel her loss and hope to tag some new advocates moving forward. The main thing that's happening nationally that I want to bring to your attention is that discussions regarding the reauthorization of the Older Americans Act have started. That legislation was last renewed 5 years ago. And as long as there's appropriations, we don't have to worry about it going away. It does give the legislative opportunity to modernize the act each time it's up for reauthorization. You may recall us talking about the regulations that were just published or were recently published, which also updated Older Americans Act. Those hadn't been updated for like 30 years or something like that. But at this, you know, they can only go so far. They can only go so far as the act itself. And so there were still things in the act we want to deal with that the regulations weren't able to. And so in your packets is included an RFI, which is actually due tomorrow. But in case you have some burning issues you want to submit, there is an RFI that was issued by a group of 6 senators that are working on the Older Americans Act legislation. And one of those senators is Senator Braun. And we've been working closely with his staff on, you know, Indiana preferences, at least from the AAA perspective, on issues in the Older Americans Act that weren't addressed in the regs. And so we really have a really good opportunity to have some influence. You know, I've kind of, the staffer and I are starting to have some regular meetings. So I would invite you, if you have particular issues that you have questions on or want to run by or maybe suggest, I'd be happy to consider those and discuss those with the staff person. So just know that's out there. In your packet, I included a 1-pager of what our national AAA priorities are. And then there's a bigger document that provides more detail on those priorities. I just kind of excerpt what I'm calling page 3. The things that really affect Indiana from a AAA perspective are the ability to not have the state have to review every outside contract an area agency on aging may have. And that's a current interpretation that's happening in some states with the regulation. Our state has been very, has had a very light touch on that topic in ensuring that we simply are administering Older Americans Act funding correctly, and that we're not having conflicts of interest, and that we're not using that funding to support outside contracts. But as you can imagine, with this move to managed care and Community Care Hub of Indiana and all the kinds of things that area agencies on housing and nutrition programs and transportation and ostensibly because they are designated a AAA, there could be an interpretation that a state has to somehow review and approve all that. And the regulations tried to address it, but they kind of also made things muddier. And so we're just trying to fix that in the act itself. Another priority of ours is in the nutrition titles. We'd like to just see them combined so that we don't have artificial barriers to addressing community needs. When the pandemic hit and we had a lot of flexibility, there was a lot of innovation nationally, grab and go meals, restaurant vouchers, all kinds of things to address senior nutrition and food insecurity concerns. And some of the barriers to that innovation exist in the act itself because those titles are separate for congregate and home delivered. So we would like to see this combined. It doesn't mean one would go away. Certainly, there's all kinds of models that we could implement within those regulations. But with those strict titles, it's hard to innovate and blend and do other things outside of those 2 initiatives. So that's a recommendation we have. Another thing that happened during the pandemic is that the act requires that healthy aging prevention programs that we deliver under Title D, 3D, is that they must be evidence-based. But when everybody had to go virtual, there were a lot of programs that just had to stop because the evidence-based did not support Zoom or delivering things virtually. So we're suggesting to ratchet that language down to evidence-informed so that we can respond to local conditions, local capacity, et cetera. We're not saying evidence is a bad thing, but we just want to make sure that we can respond to local conditions, emergencies, things like that. I think the other big thing in the act is the administrative percentage allowance is 10%, which if you look at nonprofits today, you know, a good benchmark is 18 to 20. And particularly with our state, because we are doing care management and because we're collecting clinical information and we're collecting personally identifiable information, all this protected health information. The state requires us to be HIPAA compliant, which we think is a good thing. But that includes technology. And we all know that, the price of even cyber insurance to cover our HIPAA stuff, the technology cost itself, the costs of to appropriately and steward the funding and to ensure it's administered properly through financial management and oversight. Accountants cost more, your executive leadership costs more. And so we think it's appropriate to increase the admin percentage. It doesn't mean that the AAA has to pull it all down, but we want to make sure that that's available. So those are some of the top priorities. There's some other priorities in there that aren't quite directed at our local needs, but happy to talk with you about some of the things our national is talking about. Also included in there is that US Aging also released its set of national policy priorities even beyond Older Americans Act. So I've included those there for your review. Another thing that's happened nationally is that there is a notice of proposed rulemaking on accessibility of medical diagnostic equipment. And this has been an issue out there for a long time. And I can remember even talking and thinking about this prior to the pandemic. But think about things like people going into a doctor's office for an examination, and think about those examination tables. You have to step up on a box and then you step up on a table, and even things like that. Those are the kinds of things they're talking about. And to bring rules around that so proper.
Only for women. I just thought I'd say.
Yeah. Well, but even people who can't get on just a normal table, right? How do you have a table that's down here and can raise up, so somebody in a wheelchair can transfer or things like that. So those are some of the things that regulation is trying to address. I'm not quite certain when the comment period ended, but if that's an issue for you, there's information there that you can speak further out on. So the other thing we're keeping an eye on nationally is appropriations. It's kind of that season, both in terms of continuing resolutions to make sure this year continues to be funded, as well as the coming fiscal year, the coming federal fiscal year. But there's just so much going on. We're kind of focusing on OAA reauthorization rather than a lot of appropriations advocacy right now. So that's the federal level. Anybody have any questions on that? Okay. So from a state perspective, I wanted to highlight 3 bills that passed that I4A advocated on that we think are good things. The first is House Enrolled Act 1067. That had the language in it that we talked about for a long time in these groups about rejiggering the membership of the Commission on Aging and the Choice Board. So the language that we had included in our preliminary drafts, which I shared with you last time, did find its way into a bill and it passed. So that means we get to add people from IHCDA. We get to add or are required to add persons with direct service workforce advocacy expertise. We get to make sure this group has representation around mental health. We get to make sure that both groups have representation of either a consumer of service or their caregiver. And because we're hybrid now, that's going to make that a lot easier. So the act, there was an emergency declared for this act, which means it goes into effect when the governor signs it, rather than having to wait till July 1st. So we're excited about that. There's a lot of other stuff in 1067 that you may have an interest in, but I did highlight the relevant language for the stuff that we had talked about. Another thing that we advocated on was Senate Enrolled Act 109. And this is the bill that gives FSSA kind of maximum flexibility in how it administers APS. So it now has legislative authority to kind of carte blanche, design the program they want to design. And this is important because in May, we're expecting promulgation of new final national rules that require minimum requirements of states and APS. There's never been a national APS rule, and it's coming this May. And so we believe the state should have flexibility in their ability to meet those requirements, whatever they may finally be. And we also believe this gives them flexibility in just updating and bringing in best practices and focusing more on assessment and referral to services and things like that. So Leslie kind of previewed a little bit of the work they're doing, and I'm sure she'll have updates for us as that continues.
So that will fall under the Division of Aging.
Adult protective services, yeah. Yeah.
Yeah, okay.
Yeah, thank you. So we were excited to support that, and we, even before the bill got a hearing, we're talking with the author about what can we do to make sure this moves forward. The final bill, gosh, is it 1352? Let's see. 1385. There was language in there, which we haven't really talked about with the commissions and the choice board before, but there's a mobile integrated health movement in the state happening under the auspices of the Department of Homeland Security. And we want to support that because a lot of these mobile integrated health initiatives empower EMS professionals to engage more, not just on emergency runs, but do proactive things with the community. And this gets to things like chronic disease management, injury and fall prevention, preventing hospital readmission or admission to emergency department, things like that. These are all things the AAAs are interested in too. And so we want to support that and build synergy around the things we're doing in hospital readmission, in care transition, in fall prevention, in chronic disease management, et cetera. So there was a bill in there, and I think it's really more focused on some mental health stuff. But there's a bill in there that starts to create some more flexibility for local units to find support, funding support for, these kinds of initiatives, because they typically aren't paid for in the current kinds of funding streams they have available. So there was a second bill that would have actually allowed mobile integrated health to bill commercial insurance, which died, but there will be work continuing over the summer, hopefully to move forward some of that administratively. And those efforts from our aging community perspective are primarily being led by AARP. So I'm not trying to steal their thunder there, but it's important that we all support those kinds of initiatives. From a state level as well, these kind of look random and out of order, but in the packet. But there are two articles, one that talks about a state that has gotten approval, Medicaid waiver to test Medicaid funds for housing. And this is slightly different than the model that Dan is talking about, but it gets to just paying rent payments in general, particularly when there's a significant health-related social need. And this is kind of what we're encouraging FSSA to explore. And it's because it would be expensive. It certainly requires legislative engagement. And so we're proposing that there be legislative study over the summer. And we're working with some legislators to get that proposal in. There's also a proposal and a document in here about social isolation, loneliness, and elder maltreatment. And so one of the risk factors for abuse, neglect, and financial exploitation is that social isolation. And so we really want to explore, we want to highlight for the state legislators and explore how, what AAAs are doing around social isolation. What are the kinds of models that we can implement, community health workers, other kinds of things that kind of all support decreasing social isolation among older adults and people with disabilities or vulnerable adults in general. So we're also proposing that for legislative study. We'll just see where it goes. We can propose it. It doesn't mean they will adopt that. The final thing, there's a bunch of other housing stuff in your packets. Dan kind of touched on a lot of that. But the other thing I wanted to highlight was work we do in the Senior Medicare Patrol Program around Medicare fraud prevention and medical identity theft. And there is There have been news stories coming out about the latest and greatest fraud being urinary catheter scams. So people being charged for urinary catheters on a monthly basis, they, aren't even using. There were some articles in the national press, Washington Post, New York Times, that came out a couple weeks ago, talking about how this National Trade Association of Insurance Processors found this scam. But actually, we were talking about it in SMP last fall and August and September. And that's how the government starts to find some of these scams, as people are, individual consumers are looking at their Medicare summary notices going, I didn't get that service. There's DME here I didn't approve. They report it to SMP. We forward it to the Office of the Inspector General. And so we're a conduit to receive complaints, so we can forward that stuff up, but we also put out all kinds of messaging. And so I've included in there messaging and information about a news story that's going to break today that we have worked on with Channel 6. We are going to be, I included some of the Facebook stuff that we put out. We do social media marketing with this. We boost posts on Facebook, et cetera. And then I also included the national press articles. Senator Braun has taken notice of this in the Senate Special Committee on Aging. So it certainly is something that is you'll hear in the news. But I did want to highlight the service that we have in Indiana that's consumer and caregiver facing about helping people to it is protect, detect, report is kind of the tagline. Protect yourself, know how to detect it, and when you do detect it, know where to report it. So I'll stop there because I think we're at time, and you can certainly reach out with any other questions in your packet.
Any other comments or questions for Kristen? Okay, well, thank you so much. Another very full and productive meeting of the Commission on Aging. If there's no other business to be brought forward, we'll adjourn the meeting and we will meet again on May 16th. Thank you, everyone.